Okay, friends, I have some good news and bad news. The bad news is first that I have some important function today, which I completely overlooked when the dates were blocked. So I'm going to introduce the topic in today's session and the next session, and then I hand over to Dr. Bajania to do the needful. And I'm sorry, I will not be able to continue as a panelist. So Dr. Kasi and Vijay, of course, they are very able panelists. They will continue with, if possible, in between, if I get a chance, I will join. I'm in a place where it may not be easy to join. All right, so first let me share my screen.
Yes, Chetan, good evening.
Yeah, good evening.
You are able to see the screen, right?
Where is Jaideep?
No,
No,
Jaideep is not there. I was
Jaideep
supposed to
not
be there.
Yes, Jaideep was not there.
So, are you able to see my screen?
Yes.
Yes, sir.
All right. So, two changes have happened. First of all, we have joined hand with the SDPDA, that is the Surendranagar District Pediatric Doctors Association, which is essentially the IAP branch in the Surendranagar district, because our president, Dr. Basavaraj, had requested that we bring it under the fold of some IAP forum. I had actually asked whether we can do it under his action plan, but it was too packed. Then we tried with Gujarat State branch, but there was some confusion. So we were trying for the Surendranagar branch to do it. And they have very graciously accepted our invitation. So this Gujarat Pediatrician WhatsApp group will continue its monthly webinar along with the Surendranagar District Pediatric Doctors Association. And thanks to Dr. Krunal from WAPI for guiding us to register the Surendranagar district branch. And of course, you know, in Surendranagar, there's only one Don, and that is Dr. Ramesh Bajania. So he was the man behind getting this done. So good, we have brought it under the umbrella of one IIP forum. Today, we have the second part of the vaccination, and I'm sure vaccination is going to run over at least 6-8 sessions. So we will alternate vaccine with another topic so that it doesn't become too rhetoric and too boring. Okay, these are the sessions we have done so far. We started 6 months back with the first session on the hematology labs, and in 6 months we have already more than 2,200 views. Then we had the TB confusion consensus with Dr. Yevle again, and Dr. Sushant Mane and Dr. Varinder Singh, and again more than 1,300 people have viewed this. Then we had a very interesting session with the maestros of rheumatology. On jaundice anxiety, that's on the JIA. So again, that was in the month of May. We had more than 1,001 views, and but 1 month we had the first part of the nephrology, where again we had 3 eminent specialists from the country to deliberate on the nephrology part, and again we have more than 1,200 views. In between, we had one vaccine session which unfortunately could not be uploaded in time. So we don't have the data on how many people viewed, but we are back with the second session today. And just to brief you, as I said, the second thing that we have changed is that we have changed now onward the timing on, instead of Thursday to Friday. Because Thursday it was clashing with the IAP VAC program. So a lot of people who wanted to attend this vaccine session and also other session had requested, it's a paid program through under central IAP, we didn't want to clash it. And on Thursday, there are a lot of other groups which are doing like adolescent groups. So they all requested that we should not have the important function on the same day. So we have, from October onward, we are shifting from Thursday to Friday. So on 11th of October, which is the Friday, a day before Dashera Day, evening 9 to 10:30, we will have the session in endocrinology on growth monitoring. And I have titled it, says that if you monitor the growth in your day-to-day practice, it not only helps the patient, but it also helps you grow your practice, because you will have a cut edge over the others who are not doing it. And seriously, we will discuss to the need of growth monitoring, as well as some cases as to how growth monitoring help to click some clinical cases. So again, we will have myself and Dr. Ramesh Bhajan at that time moderating the session, and very graciously, we have Dr. Shalmi Mehta. She's a very prominent endocrinologist from Gujarat itself. We have Dr. Alok Sardesai, who works with me at Hinduja Hospital. And we have Dr. Hemchand K. Prasad from South. All three have agreed to participate on 11th of October. So we will have a very fruitful discussion on growth monitoring. So do not miss this, but please note the change that now on it will be not on Thursdays, but Fridays, and the same time 9:30 to 10:30. So with that, I will stop sharing my screen and hand over the mic to Dr. Ramesh Bajania to carry forward the introduction of the eminent panelists today. And before that, Dr. Trambak Datta from Zydus Vaccine for giving us always this link to help us conduct this program. So maybe 2-3 minutes, Dr. Trambak, you can speak. After that, Dr. Bajania can take over to introduce the speaker and the co-moderator, Dr. Chetan Trivedi, and then take forward the entire discussion on the vaccine. And as I said, I will leave, but promise that if I get a chance, I will join back through my mobile as and when possible. So with that, I hand over mic to Dr. Trambak.
Thank you so much, sir. I'll just share my screen. So I'll just quickly run through. So I am a senior medical advisor at Zydus Vaccines, and just to give you an introduction about Zydus, as all of you are already aware of, it's a well-integrated pharma player with a proven track record, over 23,000 people impacting lives across 4 continents. With more than 1,400 research scientists and 300 plus generic products, along with biologics and vaccines. So, of course, we have been launching products that address unmet healthcare needs. These are our top biologics and vaccines, including Vacciflu 4, India's first tetravalent influenza vaccine. If you see the journey very quickly for Zydus vaccines, the typhoid and Hep B, Vaxirab N, we acquired Aetna Biotech in Italy, Vaxiflu S at that period of time. We launched, which was the first vaccine to be launched in terms of H1N1 vaccine. Then we launched the division Vaxiflu, Vaxicare, Vaxiflu 4 was launched, Zyvac TCV, Twinrab, and Zyvac MMR. So we have a plethora of initiatives like We Care and initiatives like Typhoid Doesn't Discriminate. And before finishing, I would just like to tell you all that Vaxiflu 4 is now updated with Terumo 25G needle. So thank you so much for this opportunity. Over to Dr. Bajania. Thank you.
Yes. So good evening, respected seniors, dear friends, and members of Gujarat Pediatricians. Once again, I feel very happy and humbled to present one more episode of Pure Academic Bonanza. Vaccinology Part 1 has already been uploaded on Gujarat Pediatrician YouTube channel. So previous other webinars also. Please webinar this in channel, and you can keep these programs. Today we have got a very eminent academician in form of Dr. Ranganath Daruru, professor and HOD of Mamta Academy of Medical Studies. He is a chairman of PIDA 2024. He had advanced training in neonatal ventilation at Chicago in 2007. He was short-term scholar at OU in 2003. He has teaching concept pictorial pediatrics. Eminent academicians we have got as a chief guest. So over to Rangnath Daruru, sir. Please bless us with few words.
Thank you, sir, for the introduction. And thank you for giving me a chance to be associated with a webinar series where there are no advertisements or there are no happy day greetings, or there is no place for any election appeals or this. I learned this about your webinar series, sir. And I heard that you have started your journey in 2015. And so 9 years of hard work has brought you to this place. And you have disseminated much appreciable knowledge to all the people, even including during the period of COVID also. So I wish you all the same journey and a successful journey, and this to be remain as a neutral and a non-political base for learning from a PG to all the stalwarts also, because time with time we have to change and learn and update ourselves to be in the field of serving the nation and the children. Thank you for giving me this opportunity, sir.
Thank you, Darura sir. Thank you. As Nitin Bhai said, we have got two eminent panelists today. Dr. Nitin Bhai had an emergency social engagement, but if needed, he will be peeping in. We have got Dr. Kasi sir, Dr. Vijay Evle sir, and I think they don't need any introduction. Otherwise, it will take another one session. So I have got very eminent academician, Dr. Chetan Trivedi, who will be moderating along with me. And straight away, sir, should we go to webinar now? Yes, sir. Vijay sir.
Sure. Yes, sure.
Yes, sir. So Chetan, first let's have hepatitis B, because in previous webinar we had BCG, right? So, sir, what is the definition of birth dose hepatitis B? Anyone of, I mean, you can take it, of course. So, what is definition of birth dose of hepatitis B? Because in every file, pediatrician's file, the birth dose has been written. So, what is actually birth dose?
Okay.
Yes,
now, birth dose is a dose of a monovalent hepatitis B vaccine given as soon after birth as possible and definitely within the first 24 hours.
Yes.
If you just go back in time, a few years back, before I think 2000 and before 2017, if I'm not mistaken, we were giving hepatitis B within the first 7 days after birth. And then about 7 years came, before came this concept of early birth dose, and which has now become the standard of care. Now, what is the importance of this early birth dose is we must remember that in our own country, almost 40% of fresh acquisition of hepatitis B in the first 5 years is because of horizontal from contacts in the environment and community. So we need to prevent this as well. And for this, we definitely need an early birth dose. Data has shown that if you give the vaccine within the first 7 days, you can reduce the incidence, the carriage of hepatitis B by about 50%. But if you give it within the first 24 hours, you can reduce it by 75 to 80%. So a birth dose is a must. And I think it should be an endeavor for every pediatrician to see that the birth dose as early after birth, but definitely within 24 hours is given.
So, as you said, sir, in private practice, do we really give birth dose?
Actually, I have not been doing much of neonatal work for the past 7 to 8 years. But at least in the place where I practice in Bangalore, I think almost all babies born in the private sector get their birth dose within 24 hours.
Okay, okay.
And there's no reason why it should not be done.
If I may add,
Yeah,
if
please,
you look
Vijay
at the
sir.
statistics, not 100% of institutional deliveries get birth dose, which we are supposed to give as early as possible, preferably within first 12 hours. If not 12 hours, at least within 24 hours. I'll tell you my story at Navi Mumbai Municipal Corporation. Many corporation hospitals had fixed days for vaccination. You know,
Right.
for example, in NMC hospital, it used to be Wednesday, every Wednesday and Saturday. So babies who were born in between the vaccination, then we had to talk to the corporation authorities
Yes.
and get it changed, and now they are following it. So similarly, there are logistic constraints and several issues where birth dose unfortunately not practiced as it should be as per the recommendation standard of care.
Yes, sir.
Right.
Now, sir, so many pediatricians, they visit the delivery places along with the resuscitation bag. So, considering hepatitis B is relatively heat stable vaccine, so can we keep it along with vitamin K in our resuscitation bag?
Okay. Now your question brings in the concept of what is known as a controlled temperature chain, or what is known as CTC. Now this CTC is a maneuver which permits specific antigens to be kept outside the cold chain of 2 to 8 degrees for a specific period of time, of course, under strict controlled conditions. Now, this is useful, especially in outreach areas where cold chain maintenance is difficult, especially when there are disease outbreaks where you have to immunize literally on the roadside. Now, the WHO has done a lot of studies, and so far we have 4 vaccines which qualify for this CTC. They are the oral cholera vaccine of Shankol, which is now being phased out. That vaccine can be kept for almost 40 degrees for 4 days. Both the Gardasil 4 and 9 also qualifies for CTC. You can keep them at about 40 degrees again for 3 or 4 days. Then Menafrivac, that Group A meningococcal conjugate vaccine of Serum Institute, also it's pre-qualified for this CTC. And surprisingly, the typhoid conjugate vaccine is an extremely heat-stable vaccine. And it is pre-qualified for CTC at 40 degrees for almost about 30 days. And at 55 degrees, you can keep it for about 7 days.
Oh.
Hepatitis B is still not pre-qualified for CTC, but there are a lot of studies being done and a lot of pilot studies are being done. And I don't think it's long before hepatitis B also enters the CTC.
Okay, yes, perfect, sir. Now, what is open vial policy, sir?
Shall I take this?
Yeah, please, sir.
Okay. Now, with use of multi-dose vials, there were situations when there were a lot of wastage of vaccines. Vaccines which are stable. So in 2014, the WHO came out with what is known as the multi-dose vaccine policy, MDVP. Now, what is this MDVP? A vaccine qualifies for MDVP if what is MDVP? It is you can keep the vaccine, reuse a multi-dose vial for up to 28 days, provided the expiry date has not been passed, a proper cold chain is maintained, proper aseptic precautions are followed during withdrawal. The septum, you don't keep it in a earthen pot with water. It should not be submerged in water. The VVM should be intact. And it is very essential that the date of the first puncture should be written on the vial. So if all these are satisfied, a vial qualifies for the MDVP. Now, there are a few vaccines which qualify for MDVP. Generally, they're the liquid pentavalent vaccine, then tetanus containing vaccines, DPT, and even the injectable polio. These are some of the vaccines which qualify for MDVP. All multi-dose vials do not qualify for MDVP.
Okay. Now, sir, many.
So, Dr. Kasi, I have a question to ask.
Yes.
Once you, I mean, in this multi-dose vial which are used on field in public health programs.
Yes.
Can they really be used up to 28 days under the open vial policy?
If you have enough vaccines left over.
Okay, because most of the multi-dose, there is a recommendation that once you open the vial, you discard it after 6 hours.
So these 4 or 5 vaccines have been studied and they are pre-qualified for multi-dose vial, not all the vaccines. So only certain multi-dose which have been studied and shown to maintain sterility, if all these precautions are maintained, they can be used.
Correct, sir. Now, second time after opening it, कई लोग spirit से ऊपर साफ करते हैं, so that is advisable before withdrawing?
I think this is a very difficult question. Now, there is a standard recommendation that the septum should be cleaned before inserting the needle. This cleaning need not be done with just spirit. Even sterile water will do for cleaning the rubber stopper.
Yes, sir.
It is essential that it is to be cleaned because that is one of the preconditions for pre-qualification of any vaccine in the MDVP.
Yes, sir. Yes, Chetan, please take.
This is what routinely what we follow, because hepatitis B multi-dose vial is there.
Yes.
Right? Those vaccines which come in multi-dose vial, we use it, we keep it in refrigerator. So do we follow that policy?
Yeah, hepatitis B comes under the multi-dose vaccine policy. Hepatitis B vials do qualify for the multi-dose vaccine. Can't hear you.
Chetan, I think you have an unstable connection. So let me take meanwhile. Now, sir, if I'm sure that HBsAg negative status of mother, I mean, I know that it is negative. So can I defer it to day 5 when I call newborn generally for routine checkup for CHD and icterus? And nowadays, particularly, the second part of the question, that hepatitis B is very running shortage. So
Yeah,
does it have any implications?
So the
You're
very
muted, Vijay.
yeah, so the very
Yeah,
purpose
Vijay, you're
of
muted.
No,
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 I'm not.
audible, sir. Audible, sir.
Can you hear me?
Yeah, yeah.
Yeah.
Yes.
So the very
Vijay is
purpose of
muted.
I'm not muted. I mean, you are not able to. Can you hear me, Ramesh?
Sir. Yeah. Everyone. Yeah. Please,
Yes, sir.
please.
Yeah.
Yes, sir.
See, the very purpose of giving hepatitis B at birth as soon as after birth is to prevent, infection in the newborn baby. And apart from the vertical transmission, the other mode of transmission is horizontal transmission. Uh, so deferring it in a HbA1c negative mother is not the standard of care and does not really make much sense. So regardless of the serostatus of the mother, any newborn baby should be administered the birth dose as soon as possible after delivery.
Correct. Yes, Chetan. Chetan, you can take it.
Very sorry,
Unmute.
my internet connection is very unstable, unfortunately.
No, please go. Right now it is okay. Please.
Yeah, fine. So I'll just share again. Okay. So we finished that first part of it. Now, sir, is there any chance that a person who has received the hepatitis B vaccine, he has already documented seroconversion? Can he still get hepatitis B infection if he's been exposed to this thing? So is there something like mutant, something should we worried about, we'd be worried about or not?
To answer your question, there are two situations where a seroconverted person can still acquire hepatitis B. One is, of course, if he is immunosuppressed, in which case, if the B cells have also been, function has been reduced significantly, the vaccine will fail. And next is mutants. You see, mutants are an important cause for vaccine failure. And fortunately today, no, not in our country, we have two vaccines. One is an adjuvanted hepatitis B vaccine called Heplisav, and the other one is called Trihebrio, which contains HBS, pre-S1, pre-S2, all three. Now, these deal with mutants very well, and these vaccines are recommended now in the newborn immunization schedule in quite a few countries. But mutants is an issue. In our own country, the existence of mutants in a population is hardly 1 to 2% of the population. So I don't think it is a clinical issue as far as our country is concerned.
So this is a rare thing which can happen.
Yes.
So we may not be saying 100% you may not have it, right?
Yes.
It's like that. Okay. Now, sir, there was one of the gynecologists who called me that he got exposed with the blood of the hepatitis B positive person. Now, while he was doing the surgery, some way. Now, this is for adults, but if I have an adolescent, maybe weighing 60 kg, right? He has been exposed to this thing. He has, suppose, not documented seroconversion, right? Now, 60 kg, and what will be my action now if he has been exposed to hepatitis B positive things and he has
Okay.
not documented seroconversion? So, my question is, because yes, we will be giving hepatitis B, we will be checking it, but what about HBIG? And what will be the dose of that in adult, almost 60 kg child?
I think in this situation, we have two options. Suppose the source is known hepatitis B negative, one need not bother about it.
Okay.
But if that is not known and you do not have documentation of an antibody titers, in that case, this particular gynecologist, if possible, feasible, should have immediately an anti-HBs IgG estimation done.
Okay.
You can get the reports within 3 to 4 hours also.
Right.
If the titers are more than 10, you don't do anything. If the titers are less than 10, you will give the immunoglobulin and the vaccine first dose.
Okay.
The dose of immunoglobulin in adults is about 0.06 ml per kg of the HBIG. You have the option of giving HBIG and the first dose of the vaccine. 4 weeks after that, you can do the anti-HBs IgG and see whether he has seroconverted. If he has seroconverted, nothing more. If he has not seroconverted, you give 2 more doses and again re-estimate 4 weeks after the third dose. The IAP recommends that you continuously give off 3 doses. That is, you again give a second schedule and then do an antibody titer 4 weeks after the third dose. So that is what is to be done in this particular situation.
So,
So
sir,
the lesson is that I think every healthcare personnel should take the vaccine and document seroconversion. It is extremely important.
Yes.
now, sir, what I
So,
read,
Doctor, can I this is
Yeah.
a question which is asked very often by many
Yes.
doctors as well. Now, see, we say that hepatitis B, the antibody titers are bound to wane over a period of time.
Yes.
And routinely, if a person is immunocompetent otherwise, we do not really recommend an additional dose, hepatitis being a disease with not a very short incubation period.
Right.
So in such a situation, why this adolescent, even if you document titers and they say they are below 10, why should he receive HBIG and hepatitis B?
If you have a documented titer at some time in the past and now the titers are no longer detectable, you are on safe grounds.
Hmm.
But if you do not have any documentation of titer, there is a possibility that this guy may not have responded to the first
Non-responding.
dose of vaccine.
No, I'm talking if the titers are below 10. They are detectable, but below 10.
See the whole thing here is that if you have a documentation of previous positivity, here irrespective of the titer, less than 10 or even 0, you don't do anything. But if you do not have that, because of the tendency for this disease to develop chronic hepatitis
Yeah.
and the strong link to hepatocellular carcinoma, you got to be overcare. Almost like rabies.
Correct. So one would err on safer side and
sir,
give it.
now the
Yes.
question is that fellow decided because had first I told him you just go for vaccine because they were very much apprehensive. So they take a vaccine, like first take a sample of that titer, anti-HSV antibody, give the vaccine. And what about hepatitis B immunoglobulin? Then his titer was less than 10, right? So then we had to give the hepatitis B immunoglobulin. Now you
Right.
said 0.06 ml per kg,
Yes.
right?
There is a
Now,
maximum limit also, I think 5 ml something. I'm not very sure about that
5
dose.
ml. 5
so
ml is
But
the ceiling
there is
dose.
a maximum dose also.
so
Yeah.
what I saw, just this is the some error 0.06. Okay, so it will make it 3.6 ml,
Hmm.
right? Now one HEPA is containing 0.5 ml 100 units.
That's right.
So how to manage this? If it is 3.6
No,
ml, whether
hepatic,
we, hmm,
no,
so we are
hepatic you have 0.5 and 1 ml also. Adults use a lot of 1 ml and 2 mls.
okay. So that will be 200 ml, 200 units.
You got to give multiple doses. If it's more than 5 ml, you got to give at 2 sites.
Yes, but what about that? We have to count the units or ml.
We are using usually ml because the concentration is standard. I do not know what the concentration is, but the concentration does not vary from product to product. It is uniform.
Right. So because this was real problem because and then
Yes.
4 5 ml how to inject at the same time. So we have to divide it
Divide.
then
Yes.
divide it.
Multiple doses. Yeah.
So
Yes.
so so this is what practical situation we came across.
Right.
Anyways, uh, suppose sir, if I am
This
very sure,
this we have taken, Chetan.
okay, no no no. No,
Yeah, I
what I
think.
am here the situation is suppose I have attended a call of the newborn delivery, right? And there I know that its child is HbSAg negative, right? So usually what we have the practice in our practice is like we call them on day 5 just for routine checkup, so cardiac observation, malab whether there is some murmur or there are not, and to check whether jaundice so can I defer it because I don't carry the hepatitis B vial with me and it is difficult. So can I call him at day 5 for routine checkup in case where I am very sure it is hepatitis B negative mother?
The mother may be hepatitis B negative, but what about horizontal? That ayah may be, the nurse may be, the lady who comes to bath may give, some family member may be positive. I don't think we should take a chance. This is very important in our country. 40% is horizontal. So I
Mm,
think it is imperative that you should give the birth dose, irrespective of whether mother is positive or negative.
mm.
Okay, so
Yes.
I think we should have a practice of keeping a hepatitis B vial at the
Yes.
gynecologist's place and then give it with the
Yes.
vitamin K, and then you call
Done.
for the day 5. So that is what
In
a practical.
fact, I think it is more important to give hepatitis B first rather than vitamin K, given a choice
Uh,
between the two.
Okay, okay, okay. Now, suppose the newborn who has not received birth dose of 0 OPV or hepatitis BCG, now he comes to me at 1 month of age, right? Now, should I give the vaccine hepatitis B and BCG now and call for DPT containing vaccine at after 15 days, or I have to keep a gap of 1 month? So this is a practical scenario. Patient has come at 1 month to me. He has not received the birth dose. So what should be my schedule? How should I start?
You want me to take or Vijay will take it?
Vijay sir, what
This
do you
is a
say?
very tricky situation. So in my practice, I'll tell you what I do. If I'm very certain about the sero status of the mother and the family and who's taking care. Now it's already 4 weeks.
Hmm.
So what I do is I defer it by 2 weeks and then call them for hexavalent vaccine. This is what I follow in my practice.
Can I?
Yeah.
Yes, sir.
Yes,
Okay.
sir.
Now, BCG and OPV, there is no issue. You give it off. Questions come is hepatitis B. If you give at 4 weeks, the next dose is at 6 weeks. And you know, between two inactivated vaccines, minimum 4 weeks interval, grace period 4 days. Okay. You must remember that hepatitis B is a very, very strong immunogen. And that's the reason why you can give the antibody and the antigen together and there will be no interference. So even if you give the dose at 4 weeks and you repeat a dose at 6 weeks, at worst, the 6 weeks vaccine, hepatitis B, may be marginally blunted, but that will not make any clinical difference. But when you give at 4 weeks, you are sure that you are not postponing initiation of protection. Again, looking at the view that we have quite a significant amount of horizontal transmission. So I would prefer to give hepatitis B and then repeat again the hexavalent or pentavalent at 6 weeks.
So sorry, but this is a real practical scenario. This you never find in any books, this kind of question, but actually we are facing
No,
daily.
see, there are a lot of situations which is not in the textbooks. So you
Yes.
got to take expert opinion. And you know, when you take the hierarchy of evidence, expert opinion is the lowest. It's
Is the
not
lowest,
that.
yeah.
And
I'll tell
expert.
you, Chetan, there are a few areas or metros wherein, though I agreed it is not time to change over to 2 months, 3 months, 4 months, but
Yes.
there is a view that you could give the hepatitis B at 4 weeks and then defer the hexavalent to 8 weeks.
I think no. I
Those
don't
are-
think that is right.
So,
No.
yeah. So that is, I mean, it's highly individual. I mean, I know a few pediatricians who are in Delhi who practice
Yes.
2 months,
Yes.
3
Yes,
months,
sir.
4 months schedule.
So that was also one of the questions. There are pediatricians for their own child. They want to give the best immunology. So they said 246 is best immunologically. Why not to go for 246? So this is what the
Okay.
discussion goes on.
I'll
Do you
tell
want
you
me
the
to
answer
comment?
to this is
Yes, sir.
there is
Yeah,
a
please.
there is a risk window here.
Hmm.
We know the disease epidemiology in our country. So, and that's the very reason we have not yet changed from 6 weeks, 14 weeks to 2, 3, 4 months.
Yes.
So
it is
See,
not
the
advised.
it's an
the
unnecessary
aim,
risk.
Chetan bhai, the aim of any immunization schedule is to give the best possible protection and
Right.
not chase antibody titers. So definitely 6, 10, 14 is more relevant. Pneumococci, the longitudinal study done in Vellore, 2 days of age, colonization begins. Most rotavirus hospitalizations occur within the first 4 to 5 months. How can you postpone the vaccines? You should not. You have got to have complete protection as soon as possible. And for that, I think the 6, 10, 14, you're compromising on the ultimate antibody titers, but you're conferring protection earlier. And that is what is necessary in our country.
Very
Or
well
for that
said.
matter, developing countries.
Very well said. Thank you so much.
And all these vaccines, we follow them with boosters.
Yes.
So
Yes.
in the long run,
Yes.
it really doesn't matter.
Yes.
Bhajana said.
Now, this is a very common situation. Preterm, those particularly who are doing neonatology practice, a 30 weeks preterm newborn weighing 1.5 kg delivered to HBsAg positive mother. Then how should I manage?
So this is very straightforward. I mean, this is a preterm baby who is born to a HbA positive mother. So you would give HbIg plus hepatitis B as soon as possible, immediately after birth, and follow it up with 6, 10, 14. In the past, there was a recommendation of using, 1, 2, 6, and 12 months. But with the 3 doses now being given in
Right.
routinely, you can do away with that additional dose. As such, we end up giving 4 doses. So do HbIg and hepatitis B, and then 6, 10, 14 mix hepatitis B.
Okay.
And do not forget to document the titers in such situation.
That we are coming to.
At say around 9 months.
Yeah.
Yeah.
Now,
So,
Vijay sir,
same.
yes, sir. Anything else? Kasi sir,
No,
to-
no,
Oh,
perfect,
yeah.
complete.
Now, Vijay sir, if a newborn 14 days in now, discharged from NICU, with weight of 1.6 kg, right? So how will you proceed for BCG, OPV, and hepatitis B? That is what we are giving 0 dose.
So again, it is a sort of repetition, right? But the same thing concept is so what we want to reassure the people that even if the weight is less than 2 kg, you give the bird dose of like hepatitis B, you give it because we are going to follow it with 3 more dosages, right? So initially, previous still there are people who believe that we have to wait till 2 kg or 1 month of chronological age for giving the hepatitis B vaccine to the infant. So that's why we are putting this thing. You should give it as early as possible, and whenever the child is stable about to discharge, you should give all the 3 vaccines because even the prematurity or low birth weight doesn't cause any interference. If at all it is creating some, then we are going to give 3 more dosages. So that was one thing. So
Chetan, this was an old recommendation. More than interference, the immune response was suboptimal in preterm
Yes.
babies.
yes,
So there was
suboptimal
a
immune
recommendation to wait
response.
until day 28 or 2 kg 2 kg weight. Now, as such, we follow it up with 3 additional doses. So that is no longer valid. So give
Right.
it regardless of the weight of the baby.
Right.
Mm.
Yes, Bajana sir.
So what is rapid hepatitis B schedule, accelerated one, and when it should be given?
Okay. Now, there are conditions where you want to achieve protective antibody titers as soon as possible. And this is specifically for healthcare personnel, who are going to go to areas where medical care is not possible and there is chances of exposure, or a patient who is going to start immunosuppressive therapy, bone marrow transplant, etc. So in these accelerated schedules, usually you finish the first 2 doses as soon as possible, definitely within a month. So you give the first dose, the second and third dose are given within 2 months. And in this schedule, it is necessary that you give a fourth dose 12 months after initiating. In fact, there is a highly accelerated schedule where you give 0, 7, 21 days and then a additional dose at 12 months of age. And there are some studies which have shown that in the accelerated schedules versus the regular schedules, the seroconversion rates are almost similar, but antibody titers are far higher when you use the standard schedule rather than the accelerated schedules.
Usually what happens that there are people, the students who are going for study abroad.
Yes.
And at that time, if you find that hepatitis B titer is less than 10 and they want to give it, they have very short time. So what earliest we can give is what you said is 0, 1 and
2
5
months.
months, right?
No, now in this situation, you can give 0, 1, 2 and 12 months.
Okay. So 0, 1, 2 and 12. Okay,
12
fine,
months,
fine.
yes.
Because there is some mention that there has to be some 4 months gap between first and third dose.
See, ideally, there has to be a 4 months gap between the last priming and the booster dose. Remember, third dose is a booster dose.
Okay.
But we should also remember that hepatitis B protection is based on memory B cell and not on persisting antibody titers in the blood.
Right.
And once seroconversion has occurred means the memory B cells have been stimulated and they are going to act because there's a long incubation period. But we must also remember that if you have higher antibody titers, your memory B cell counts are also higher. The memory B cell response is also more robust. So, though theoretically the 016 is the best, But as I said again, we are intermediate endemic, so we cannot go for the 016. It's better to give the 6, 10, 14 hepatitis B.
Correct. Now, sir, what are the situations where we need to give double dose of hepatitis B or even more number of doses or boosters?
Vijay?
So children who have, say, end-stage renal disease, who are on hemodialysis, immunocompromised children, where your memory response is not very robust. These are the children where you may have to give more number of doses or increase the antigenic content of the vaccine. So apart from this, there is
in fact, patients with hepatitis C mount a very suboptimal response. You have to give double dose. Also shown that children with celiac disease tend to mount a suboptimal response. So even these are situations where you may need to give double dose also,
And
apart
sir,
from the immunocompromised.
Cystic fibrosis also?
Yes.
Yes. So usually, sir, recommendation, when I saw that recommendation, double the dose. But double the dose of what? Because recommendation is for dose is for adults. So you have to double the dose of adult, what has been recommended. But for children, do we have any recommendation? Because I didn't find that.
No.
1 ml.
Actually, if you see the literature, there is no mention of double dose in children, even in immunosuppressive. There is no data at all. We are just extrapolating data from adults because it's a safe vaccine. You give double the dose. And if in adults double dose gives a better response, why should it not in children?
Yeah.
Okay.
But there's no recommendation.
Yes. So technically, expert advice is double the dose of our pediatric dose.
Yes. Yes.
Okay. In that
Similarly,
situation.
theoretically, I mean, though theoretically we say celiac and this thing should be given cystic fibrosis, by the time we make a diagnosis in them, they are
They
beyond
must have received all. That's
But
true.
sir, there are situations that these patients, they come from peripheral, they have not received. This situation may arise. So that's the thing. And sir, do we need to check for the titers in these high risk patients, and how frequently we have to give the boosters?
Patients on the dialysis, you check their titers annually. And if the antibodies are below 10, you give them a dose.
Right.
So then if it is less than 10, then single dose or 3 doses?
Single dose.
Single dose. You
And
give a
then
booster dose.
Okay. And then do we check the titer after 1 month?
Ideally, yes. They should undergo titer check.
No, I mean, ideally, yes, but there is no recommendation for doing it in someone who has already responded initially. So you need not do it. You just repeat it every year.
Yeah.
Okay. And check at 1 year.
Yes.
Because this is the situation we face. Like the patient on dialysis, this is very common.
Yes.
So they ask us what to do.
Yes.
Yes.
So basically, so I think you give a booster dose once a year if the titer falls below. You don't have to again show that the titer has risen after giving the booster dose. It will have risen.
But this is extremely important because today only we were discussing at our institute, and one of the patients who is undergoing hemodialysis regularly, he happened to, he had documented anti-HBsAg titer, but he contracted hepatitis B because he was not undergoing annual check.
Yes, that is very necessary.
It's very, very important.
Hemodialysis and all immunocompromised also.
Absolutely.
Yes.
Now again similar situation, but a newborn delivered of a HBsAg positive mother who was routinely given HBIG plus 0 dose HB hepatitis B at birth plus 3 pentavalent vaccine. Now, which test to be done, sir, and when? To make it sure
again,
that
you demonstrate titers in this situation. If the baby has not received the immune prophylaxis with HBIG, you can do it 6 to 8 weeks after the last dose. Or if the baby has received HBIG, do it after 9 months. So that there is no interference and the results are not erratic.
So the question here is because we have recommendation that if you have given HBIG, it will remain positive for 3 to 6 months, right? So
9 months, up to 9, so you tested beyond 9 months, between 9 and 12 months.
So suppose, so not less than 4 weeks after the last dose of hepatitis B, because
No.
even
Definitely.
hepatitis B may give you a positive anti-HBsAg positive,
Yeah,
right?
yeah.
Yes.
That is one. And now, if you want to give it, so can we do it at 6 months? The question is, if it has been given at 2.5, 1.5, 2.5, and 3.5 months, 3 hexavalent vaccine and HBIG at birth, can we do it at 6 months, or you have to wait till 9 months?
It is
That's
better
the
to wait
question.
until 9 months, because HBIG effect may last up to 9 months.
Yes. You wait at 9. The standard recommendation is 9 to 12 months.
Okay.
Mm,
Suppose someone
correct.
did at 6 months, right? And he got HBsAg positive. What next?
He has missed the bus. The post-exposure prophylaxis has failed.
Right.
Mm,
So this child is going to become a chronic carrier and he has to be followed by a gastroenterologist. They have to do anti-HBC. They have to do the viral load and take a call whether they require antiviral therapy. I mean, that's something I think beyond the scope of a general
Right. Right.
pediatrician.
So
mm,
now, so better, that is
No, but
what.
Dr. Kasi's question was, if this baby was received HBIG and you do this test at 6 months, then what one may repeat it at 9 months and see if it becomes negative.
No, no, he spoke
Okay.
about
HBsAg
hepatitis B,
Okay.
HBsAg.
Okay.
positive.
Okay.
Yes.
Okay. Not anti.
Would have
Okay.
been
Fine.
HBsAg negative, then we would have
Yeah, yeah.
done
Yes.
it again.
Sorry. Sorry.
Okay, it's fine. So
Mm.
now let's. I think hepatitis B, the questions are done. But if you have the questions, you can just post it. I think we have that option of asking the question on that stream go also, right, Dr. Bajane?
Yes, yes. We take this thing, and in case of any questions, we can take it
Okay,
from the chat box.
fine. Now let us go to OPV. Now the most important question: should I be giving OPV along with all routine primary immunization series and hexavalent series in private practice? Because what happens in government setup when the patient goes, what government is offering is zero birth dose, OPV at birth, right? Then they give it with, then when they are giving, they are not giving FIPV, or I think they are giving with all pentavalent. So what is the rationale why government is doing like that, and what should be done in the private sector?
Okay. You must understand that the basic principle of OPV and IPV usage in IAP versus NIP is different. In the NIP, the primary vaccine which is going to prevent paralytic polio is OPV, BOPV. Your FIPV is more of a risk mitigation strategy. Okay. Whereas in the IAP schedule, the primary vaccine to prevent paralytic polio is the injectable polio vaccine. Now the question comes, if the government is giving OPV at 6, 10 and 14, should IAP also give? And IAP has, I think, almost about 6 years or 7 years back said we should drop OPV at 6, 10 and 14. The reason that was done is we are now shifting away from a OPV to an all IPV. We might as well start with the doses which are probably not very important when you are giving IPV. So 6, 10, 14 was dropped. And see, these recommendations are going to be country specific. I will just tell you, way back in 1997, there was a WHO study which was published where they looked at combined schedules in 3 countries, Oman, Thailand, and Gambia, where they gave 4 OPV, then they gave OPV with 3 IPV and a combined schedule. That is bird dose with 3 doses of IPV and OPV combined. What they found there was, surprisingly, OPV vaccines gave better seroconversions compared to IPV. Better seroconversion, which I think it was very, very surprising. With 3 doses of OPV, the seroconversion for all the serotypes was over 95%. But what is in our country? Even with 14, 15 doses, hardly 50, 60%. So I think the scenario is very different. So as far as IAP schedule is concerned, the 3 IPVs given at 6, 10 and 14 is sufficient, gives good antibody response, very good seroconversion rates, and probably adding OPV will not add any further. Only thing you will be adding in is further OPV load and which goes against the tenet of what we are doing, that we want to withdraw away from OPV completely. So I think this 6, 10, 14 we can definitely do without.
And 6 to 9 months also OPV not required. So what
Now
we
6
have to,
now 6 to 9 months was a different reason. 6 to 9 months was given because we had a contact at 6 months, either the third hepatitis B or the influenza, at 9 months for measles. Let's give 2 doses of OPV to increase the mucosal immunity. That was the reason why 6 and 9 months was started. But remember, mucosal immunity induced by OPV is very short lasting, lasts just for a few months. So even if you give at 9 months, beyond 1 or 1.25 years, there is no mucosal immunity. So why give?
right. So now what is the role of OPV in our practice is only the birth dose with
Yes.
OPV. There should not be any OPV in our whole schedule.
Yes.
If
Except
we
the
are giving
SIS.
all the IPV containing vaccines. Okay, so that
Yes.
is the message, very clear cut. Don't give OPV after the birth dose.
Yes.
I have a comment come question to
Yes,
discuss
sir.
with Kasi here. Now, see the OPV bird dose, I can understand. Government strategy to continue OPV along with FIPV is also understandable. And it was to begin with a risk mitigating strategy to use 2 doses. Now, having started, added yet another dose at 9 months, I think provided that the coverage is 100%, shouldn't the government also start moving away from OPV plus IPV?
You mean totally?
Yeah.
Certainly. I think that is the ultimate aim. Definitely.
So if you
The
are,
only,
if
the only,
one can ensure 100% coverage with 6 weeks, 14 weeks, and 9 months with
yes,
FIPV
yes.
and a 0 dose OPV, it's high time that the government also starts moving away from OPV along with IPV.
You
But
know,
the issue is erratic supply and incomplete coverage.
see, 6 weeks, 10 weeks, and 9 months FIPV is in no way inferior to IMIPV.
Absolutely. Absolutely.
And I think this is the first move towards moving away from OPV. It's a question of time.
Yeah.
See, IPV has to be available.
Yeah.
You know, that is the main thing. And that production capacity is still off and on. You find shortages in our country or all over the world. So I think this government schedule is also quite sufficient for the time being. Indian schedule is probably, the IAP schedule is a little ahead of the NIP schedule.
Okay. Now
So,
you mentioned supplement.
so Chetan, now
Yeah.
now hepatitis B is also not available at a national level. So does it have any implications as far as the national health programs are concerned? Because many pediatricians, they ask in our forum regularly.
Yeah, I think this hepatitis B of BE vaccines is available on request.
Hmm.
It is still in Bangalore. We are getting this BE hepatitis B vaccines in hospitals and nursing homes. You see, private practitioners rarely use monovalent OPV in their clinics. So almost all the kids are getting the 0 dose hepatitis B at birth now.
No,
And I think this shortage is something that is there almost in all the middle income, low middle income countries. And I think there is some problem. I don't know what it is, but production has suddenly reduced. I don't know what the reason is.
But it was a big problem in between. Even at
Yes.
Apollo, the
Yes.
monovalent, we do require it for the birth dose.
Right,
Private
definitely.
institutional delivery. It was a big issue.
Yes. Yes.
Now it's available. But
Now it's available.
so now what you mentioned is SIA, supplementary immunization activity, that is for OPV. We know that every year, maybe Jan, Feb, we come for pulse polio dose, right? And that is what SIA is meant about, right?
Yes.
Now, nowadays we don't see the national polio day, right? Previously, there used to be Amitabh Bachchan coming and telling everyone that it's a polio Ravivar. So now it is not there. But there is some areas where it is going on for at their own convenience. What is the reason? So that is what I want to ask. And second thing is, suppose I get a call from patient that infant who has received all primary vaccinations in my hospital, and the last dose of hexavalent vaccine was given 2 days back, and today is pulse polio day. So parents ask, will should be giving a pulse polio or not? So these two questions, if you can answer together.
This is a very common question.
so you want to take it?
Yeah. No, Vijay. No, Vijay, take it, please.
So first of all, the number of drives have gone down over a period of time, taking into consideration the epidemiology now. Now, what dictates the drive in certain pockets is the surveillance and need-based activities happen. We know it very well that regardless of the interval between the dose that the patient has already taken in private sector or otherwise, it really does not. If you be selective, then the basic principle of pulsing everyone in one go is defeated. So regardless of if the patient has received or not received hexavalent, pentavalent, or injectable polio in private or public sector, the advice should be please go and participate in that drive. You must remember one principle that what is good in the interest of community, by and large, is good in the interest of an individual also.
Right.
Let's not send out, confusing and conflicting messages to public at this juncture, which is very crucial. We are very lucky that it's more than a decade that we have not had wild polio in our country. So let's be very vigilant, very surveillant, and not falter on our advice and send out conflict messages. So I thought generally, see, the worry was VAP, but a child was receiving one single dose of
IPV.
IPV is unlikely to develop VAP.
Right.
So question is like just to make the people understand that if we are giving regularly IPV, if we are giving regular FIPV in government, why this SIA? Why pulse polio?
Because we want to people to have confidence in the public program. We don't want to disturb the ongoing public program. So it will say,
what is the logic behind this pulse polio? Why
no,
we are giving it?
If an individual misses out on that, who has taken injective polio, misses out on that pulse polio, no great deal of harm will be done. But if you by choice start advising parents not to go and participate in that, it may do harm to the community.
See, Chetan, the main purpose of this SIA was to give the largest possible number of children a single dose or 2 doses of OPV in the shortest period of time, so that you create a mucosal immunity in the vast majority of the population, and that will interrupt transmission of poliovirus. See, this is the main purpose of the SIS. So the thing is, you have to give it in the shortest possible time. If the pulse polio is today and someone comes after 10 days, it doesn't serve any purpose. It has to be given within that short time period of maybe 3 days, 5 days, or 7 days.
In the pulse, sort of.
Yes.
That's why it is called pulse.
That's why if you go to see those who do not participate in the drive at public places, the healthcare worker come home within a period of 1 week.
Yes, yes.
To wind it up in a week's time.
In a week's time.
Yeah. So same, suppose patient has missed that pulse polio government setup. If he comes to us in private sector, can we offer it? That means the question is it that what they are giving is different than what we are having? It's just the same bivalent polio?
The same bivalent polio. As I said, if they come within 5-7 days, give it. But if they come after 15 days or 1 month, it doesn't serve any purpose. Don't give it.
Yeah. Unless there is a special drive.
Yes.
Following a CVDPV case where
exactly
monovalent is being used, then it doesn't make any sense.
Right.
Right. So this is a commonly asked questions about OPV. Now let us go to IPV. Now, I think Kashi sir, this we are discussing a lot many times. Vivek sir also knows that 6-month-old child brought for the flu shot. Like he was given a vaccination as the per government schedule 6 weeks, 14 weeks FIP plus PCV. Now wants to shift at 6 months. What advice will you give at for IPV and PCV?
Okay, I'll take PCV first because it is easier. Okay. Now, question is, how do 2 priming doses compare with 3 priming doses? Okay. 3 priming doses gives higher antibody titers compared to 2 priming doses. The difference is maximum for 6B, where the titers are almost 21% higher. Next is 23F, where the titers are about 17% higher. For all the remaining serotypes, the difference is less than 10%. Okay. So from that point of view, this difference disappears by the time the child is 1 year. And once you give a booster, whether you receive 2 priming or 3 priming, it makes no difference. But remember, 3 priming gives higher antibody titers. And in our country and most of the low income countries, I won't say India is low income now, but most of the LMICs, the main reason for giving PCV is pneumonia and not IPD. Pneumonia is a mucosal infection. And we know for mucosal infection, you require higher antibody titers to counteract, to prevent the mucosal infections. So any schedule gives higher antibody titers definitely is better. In fact, there has been no study, immunogenicity has been compared, but there have been no clinical studies except for one study in USA where they compared 2 doses and 3 doses of PCV7 at that time, and they found that 3 doses definitely reduce the incidence of all-cause LRTI to the tune of 40%, the difference. So I think from the private sector point of view, 3 priming, in this particular case, I will strongly recommend a 3rd dose of PCV 4 weeks after the last dose. And then I will go for a booster. That is as far as PCV is concerned. Now, IPV is very confusing. See, in polio protection, you're looking at 2 things: seroconversion and antibody titers. Most international authorities from the public health believe more in seroconversion because the belief is that once you have seroconverted, lifelong you are protected against paralytic polio. Okay, so seroconversion is giving more importance. But IAP has also given equal importance to antibody titers because IgG from the plasma can ooze through the capillaries into the lumen of the pharynx and the intestines and add on to the mucosal immunity. There is definite data. In fact, there have been 2 or 3 studies from USA done in the late 1990s, which showed that higher your serum antibody titers, less is the fecal excretion of poliovirus following a challenge dose. So antibodies are probably titers, higher titers are more important in the transmission. Whereas prevention of paralytic polio, antibody titers don't matter. As far as you have seroconvert at some time, like hepatitis B, you're protected against paralytic polio. Okay, taking that into consideration, 6 and 14, on an average, seroconverts around 80 to 85% for all the 3. Whereas if you give 3 doses, priming doses, the seroconversion approaches almost 100% for all the 3 serotypes except type 3 where it is a little lower. Now, so definitely giving one IPV is recommended, but where is the monovalent IPV now? There is no standalone IPV. Are you going to give an additional dose of IPV containing, say, penta or hexa for this sake? I don't think that is very necessary. I think in this case, you just leave IPV alone and concentrate on the PCV. Yeah. Anything, any other comments, Vijay?
No, absolutely right. But if a standalone IP is available, you would
Then
observe
definitely.
the interval of 8 weeks and give the
Yes,
third dose and
definitely.
follow it with the toddler dose and the school dose.
Right.
Right. Excellent explanation, sir.
Mm.
Excellent. Anyways, so now similarly, the 10-month-old child brought with a TCV for TCV and it is received that 6 weeks and 14 weeks and 9 months IPV, fractional plus PCV. So now what is it? Because this is also, we have very clear message, but just repeat it for the sake of the audience.
As I said, as far as PCV is concerned, 6 weeks, 14 weeks, and 9 months is a complete schedule. The 9 months is a booster. And in fact, there has been a study done from Gambia with the experimental PCV9, which showed that just 3 doses, 6, 10, 14, protection against IPD is almost more than 80% even after 7 years. So it's going to give a lot of protection against IPD. So PCV are not going to give any additional doses after the 6, 14, and 9 months. Now, as far as IPV is concerned, again, we need to delve into the literature for this. There was a very important study done in the Dominican Republic and Panama, and that is the basis for this recommendation, where they compared 2 fractional doses given at 18 and 36 weeks and 3 doses given at 10 weeks, 14 weeks, and 36 weeks. FIPV and IMIPV, they compared it. And they found that as far as seroconversion is concerned, whether you give 2 or 3 doses, IM or IPV or full dose, the seroconversion rates are almost similar. Antibody titers are higher. So from that point of view, the WHO said that you should give at least 2 doses of fractional dose IPV, of which the first dose should not be given earlier than 14 weeks, and the second dose should be given preferably at least 16 weeks later. So that comes to around 36 weeks. When you give this, you are assured of almost total seroconversion. Now the question is, we have a 6 and 14. So should we drop the 6 weeks and only go for 14 weeks and 36 weeks? If you drop the 6 weeks, there's a window where the child is unprotected. So the government continued the 6 weeks and added on the 14 weeks and the 9 months. So this is almost a complete schedule. So if a child receives 6, 14 and 9 months, it's almost as good as receiving 3 doses of IPV as far as seroconversion is concerned. Now the question comes is, if he has received at 9 months, should I give an IPV containing vaccine at 15 months? Okay, that is a major. You have to give at 4 to 6 years because we know their seroconversion rate falls. Should we give at 1.5 years? And I think recently the 2023 ACVIP recommendation, there is no need to give.
Yes.
And this was based on the study, one study done in Bangladesh, where they compared 6, 10, and 36 weeks with the IM-IPV, and they found that the protection was almost similar. If you look at the waning of the antibodies following this 16 weeks and 36 weeks, if IM dose is there, they have a follow-up till about 21 months, that is 12 months after the last dose. Seroprotection is maintained to over 85% with the full dose, whereas fraction it comes to around 64, 68%. But again, as I said, once they're seroconverted, they are primed. So they're always protected against paralytic polio. And if you opt to give an additional booster according to the IAP schedule, it's just about 6 to 8 months after the last dose. So it's not going to serve any purpose. So in this case, no booster at 15 to 18 months, but you're going to give one at 4 to 6 years.
Very clear, very clear.
In fact, in Bangladesh, the later dose, the third dose was at 24 weeks.
Yes,
Yeah,
yes.
even
A
with
little
that,
earlier.
even with that, the seroconversion, the
Was
titers
so
were
good.
pretty high.
36 weeks. You should see the titers in this Panama Dominic. Fantastic with this 1836 weeks.
So now, suppose
So Chetan,
permanent.
I think quickly for the listeners that
Yes.
if a child has completed the immunization schedule in public health sector of 6, 14 and 9 months, there is no need to give that toddler dose of neither
Exactly.
PCR or IPV.
Right.
But do not forget to give the school entry IPV.
Yes.
So PCV also not required, right? Very
No.
clear. Okay, fine. Now, so that's what I think we discussed.
Yeah, we
for
discussed
FID.
this. Yes.
Yeah. Okay, fine. So now, OPV and IPV have taken the important practical questions. Now we'll be shifting to DPT. I think we have 20 minutes more and we'll be finishing DPT and DTAP. Okay, so sir, AP versus WPC, WP. Now we saw you talking a lot about this WP. So what recent evidences they say, and how significant is the priming with WP? And most important question for everyone, because now the pediatrician, they ask us about their own kids, that should I be at least give one first dose of WP? We have heard Dr. Kashi saying that WP is priming is very good. So just an overview about this situation.
Now, AP versus WP, I think very briefly, the immunological response, the type of immunological response, innate immunity, adaptive immunity, memory B cells, type of IgG subtype antibodies, even tissue resident memory cells, which is crucial for protection, all are definitely superior with WP compared to AP. So far, we had evidence in baboons and mice.
Yes.
But now there has been a very interesting study done where they took 2 groups of adults, 10, who were posted for a tonsillectomy. 10 had received WP, 10 had received AP. They removed the tonsils and they examined the tonsils for pertussis specific cells. Here they found that cytokines involved with the Th1 response was far higher in those who had received a WP versus AP. In the same population, they took nasal smears and also looked at the tissue resident memory cells in the nasal smears. Even this was far higher in WP versus AP. So for the first time, we have studies in humans which shows that the immunological response is better. So this is one new evidence which has come in recent years.
So just
Now,
interrupting. This tissue resident memory cell, what you're talking, it's something which is at the time, at the place of entry, it is protecting us.
yes, tissue resident memory cells are found on all mucosal surface. It is a subtype of a CD4 cell, okay? And a strong TRM CD4 response prevents additions of the pathogens to the epithelial surface. So it induces sterilizing immunity.
Yes.
And in fact, now the trend in pertussis vaccine is to go for mucosal vaccines. In fact, one vaccine called the BPZ-E1 has now finished phase 2B and will start with phase 3. It's an intranasal vaccine which has elicited fantastic levels of tissue resident memory cells. So tissue resident memory cells is now the focus as far as pertussis vaccines are concerned. Now, regarding priming, the first data which came that priming is important was one from that Californian study, Oregon study, most important from the study in Australia. See, they had an outbreak in Queensland in 2014. When they looked at the immunization status of people who had developed pertussis and they calculated the attack rate was lowest in those who had received an all WP schedule, highest in those who had received an all AP schedule, and intermittent in those who had received a mixed schedule. In this intermediate, the attack rate was lower in those who received the first dose of WP versus first dose of AP. So based on that, this concept came that giving the first dose of WP and then continuing with the AP. There is no scientific evidence, but I feel it is probably very helpful if you can give at least one dose of WP because the whole immunological response is skewed with the priming, and that skewing towards a Th1, Th17 remains almost lifelong. I mean, people who have received WP and AP and have received a booster dose of Tdap 15 to 23 years later still show the difference. So that priming dose, skews the immune response in a particular direction, and that direction which is favorable with WP remains almost lifelong. So priming is very important. So from that point of view, this mixing the schedule came. Anyway, I mean, I have just been talking about it, but I think this concept is being discussed in many countries. And in fact, now there are papers coming also from the Western world where they are combining this vaccine, of course, in animal models, not in humans. So we don't know. But anyway, I think in our country where we have the luxury of having both the WP and AP, let's try to make the best use of both.
Dr. Kasi, can I interrupt you and ask you one
Yes.
question at this point? I mean, I take your theory of that babudan that adult tonsil and nasal smear.
Yes.
I have not had a look at that paper, but uh, discussing it further, in the animal studies, it was also demonstrated that if you add IPV to acellular pertussis vaccine,
Yes.
the immune response tends to skew towards Th1, Th17. What is your view on that?
Yes. Now, this is because viral RNA is a very strong TLR9 agonist. They are agonists.
Yeah.
And if you see the difference with WP and AP, lipopolysaccharide is also TLR9. Once you have TLR9, your immunological response is skewed towards a Th1. Alum, which is contained in DTAP, skews it towards a Th2. Now, addition of a viral RNA has been shown to skew the response towards a Th1. This has been proven with TDAP IPV and not with the DTAP vaccine. There are no studies at all. Definitely, if we get more data, then I think this debate may gradually go out of vogue.
Yes, sir.
Now, sir, can we go for a mixed schedule where first dose we give
That's
with
what he answered.
yeah,
Certainly, certainly.
yeah, Right. And what should be my choice, WP or AP, if 6 months old infant who was given delayed second dose of WP containing hexavalent vaccine developed febrile seizures a day after vaccination?
See here, WP is not contraindicated, but here one can offer AP because it is less reactogenic. That's it.
Right. Right. And what should be, sir, the catch-up vaccination for 18 months of a purely naive toddler?
Vijay, I think.
016. 016. And catch up in the sense you're asking whether wholesale or reseller purchases?
Overall, catch-up.
Any same.
Any.
It will be 016. You will give
Yes.
rapid 0 dose 1 month and 6 months.
Great.
Sir,
Now,
the-
sir, yeah,
so 0,
Chetan.
0, 1 and 6, that is true. But what exactly? Which hexavalent vaccine, pentavalent vaccine, what will you give? Actually, what will you give? Or rather, how will you schedule the vaccine? Because what are the priority vaccine? Previously, Kasi sir had very nicely explained, but practically, suppose at 1.5 years patient comes and he has not received any vaccine. So, which BCG will give? You will give MMR, you will give hexavalent vaccine, and then how will you schedule that? 016 you are telling. So then,
if you use a hexavalent vaccine, you give so many antigens in one go.
Together.
Yeah. So that will be an ideal choice. You cover polio, you cover diphtheria, pertussis, tetanus, Hib, though it's not sacrosanct that beyond 18 months you don't give Hib. As a part of hexavalent, you might as well give Hib vaccine. It will not definitely not do any harm. You give
sir,
hepatitis
HIB
also.
should be given till 5 years, I think, if not received.
You don't give beyond the first booster.
But here you would give it since the
And
child.
that first booster will give protection till 5 years.
Yeah.
Okay.
So you will give 016 hexavalent vaccine. You can, if you give that in one arm, the other arm, you can use it for, I'll prioritize definitely use
MMR.
MMR. And then since if parents are willing, which I sometimes do, that you can use 4 arms and give the remaining vaccines also.
So you go for hexavalent vaccine 6, 0, 1 and 6 schedule, and in between you adjust the rest of the vaccine and prioritize the MMR vaccine, right?
Yeah, basically in a situation like this, when you're planning the schedule, you first enlist all the vaccines that you have to give.
Yes.
What is the schedule of the vaccines? Then you prioritize.
Hmm.
MMR definitely high up in priority list, apart from this hexavalent combination vaccines. If it's a JE endemic area, transmission season approaching, you will prioritize WP. If the child has come into contact with, say, chickenpox, you'll prioritize the chickenpox vaccine. So these are the ways in which you will decide upon the schedule. It cannot be a one shot for all situations.
Yeah. Yeah, Vijay sir.
Now, sir, TT, this is a very routine question that child was given Tdap at the age of 10 years, and then they sustain frequent routine cuts and wounds. So how long we don't require to give TT?
There is sufficient data to show that the protective efficacy against tetanus and diphtheria lasts for at least 10 years. So if the injury is not a tetanus prone, that is a clean injury, you can definitely wait till 10 years. But if it's a tetanus prone injury, like road traffic accidents, contamination with wood, contamination with animal excreta, in that case, you give it after 5 years only.
Oh,
So, sir, exactly
In
at
fact,
10 years, when you give,
you should positively, recommend it not to use TT frequently, which is a common,
Yes. Yes.
scenario. Chota lag gaya, go to a family practice.
Yes.
Can
So,
really
sir,
lead to adverse leg reaction.
sir,
Yeah.
Tdap we have given at 10 years. Then what is the next, when will you give the next Tdap? At 20 years or 16 years?
Okay. Ideally, it should be 20 years. Was that?
No, that was someone.
Okay. So ideally, it should be at 20 years because 10 years as far as T and D, pertussis will keep it aside. It is not even 2 years protection also.
Yeah.
So now why has IAP recommended at 16 to 18 years? Lot of studies which have looked at the prevalence of diphtheria and tetanus antibodies in the population. One study done in Hyderabad in children between 6 and 17 years protective antibody titers against tetanus diphtheria was found in less than 50%. A study done in Pondicherry looking at tetanus titers, the protective antibody titers progressively became lower and lower as age passed by. Moreover, this is the last contact period with a pediatrician. After this, the concept of regular health checkups in adults is practically non-existent. So let's boost that antibody titers for another 10 years. So the IAP decided, let's give one between 16 and 18 years. Now, should it be TD? Should it be Tdap? Now, if you give Tdap, the protection against pertussis is going to last only for a couple of years. Okay. Will it make any difference? It will not impact the epidemiology of pertussis because the protection lasts for a very long, short period. Will it protect the individual? Only for 2 years. What about transmission? Here we are entering very dangerous field. So a TD vaccinated adult will not suffer from illness because he's protected, but he can continue to transmit. So a vaccinated healthy adult will mix in the community and transmit the infection if he has already got infected. So that's the reason why
Sir, एक minute.
Just
Please mute Shripriya.
Trambak, please mute Sri Priya.
So that's the reason why even the US, which recently said that you can use TD or Tdap, why did they make the recommendation? Not because pertussis is necessary. They took an audit of Tdap and TD usage in the adolescent age group, and they found that the intent for Tdap was more than TD, though they should have used TD, should have been the reverse. They went back and looked at the adverse effect profile, and they found that more number of Tdaps did not increase the reactogenicity. So they said you can give Tdap because it is safe, not because it is more effective. So that's the reason why at 16 to 18 years, the IAP has recommended preferably give TD. There's no additional advantage of giving Tdap. Right?
Correct. Now, sir, again, a very common query about pregnancy. What should be advised regarding TT containing vaccine to pregnant lady, and how many doses of TT or Tdap and timing?
Now, see, let's first take the government schedule. The government recommendation is that every pregnant woman should receive 2 doses of TD. TT is now gone, TD. The first dose should be given at first contact as early in pregnancy as possible. And the second dose should be given 4 weeks after dose 1. This is sufficient to protect the mother and give neonatal protection also till the vaccines are given. Pertussis doesn't enter the picture at all here. It is only tetanus and diphtheria.
Yes.
Now, if you want to protect against pertussis, you need to give a Tdap, that is a pertussis containing vaccine in the 3rd trimester. The recommended age is 27 weeks to 36 weeks. But the best time is between 27 and 31 weeks. That's the time the maximum antibodies is going to go into through the placenta into the infant. And there have been studies done, that is randomized clinical trials, where they have shown that protection is better if you give it in the 3rd trimester. It is less if you give in the 1st trimester, and it is least if you give before pregnancy or after pregnancy. When given in the 3rd trimester, protective efficacy is 80 to 85% against pertussis and 94 to 96% against hospitalization due to pertussis for at least 2 months, and at least till 6 months there is a protective efficacy. And now we have population impact study from USA where they found that 3rd trimester Tdap protection against pertussis is 77% and protection against hospitalization is over 90%. So clear concept that this is the best way to prevent infant pertussis and not the cocooning strategy, which has been very disappointing. So Tdap in the 3rd trimester should become a standard of care.
So there
And
should
this
be
fortunately
first.
does not interfere with the uptake of the primary vaccines.
Now, this is an issue. There is no doubt that maternal immunization blunts the immune response to the pertussis containing vaccines that you give in the infant series. This blunting is more for WP versus AP. the blunting effect disappears by the time the third dose is given, and after booster, there's no blunting at all. But countries which have extensive maternal immunization programs have not shown any increase in infant pertussis, indicating that this blunting is not of any clinical significance.
Correct.
Right, right, right.
Yeah.
So,
Chetan,
so
you
you say
can
what?
take few questions, Chetan, from the chat box afterwards.
Just a minute.
Yes.
Kashi sir, for every pregnancy, you need to give 2 tetanus containing vaccine to mother.
The government of India schedule says that if she becomes pregnant within 3 years, then you give only 1 dose. But if it's more than 3 years, then you give 2 doses again. But as far as Tdap is concerned, you give it anyway every pregnancy, even if she becomes every year, if she becomes pregnant, you give it every year because you're giving this for protecting the infant, not the mother. And you require high antibodies. So you give it every year, every pregnancy.
So you give, suppose at first trimester TT, and then last trimester you give Tdap. That should be enough.
Yes.
Okay, fine. Yes, Bhajan sir, what were you saying?
Chat box ma questions છે થોડા લેવા હોય તો last
Okay,
5
you can.
minutes. Yeah.
Okay, just a minute. I'll take this.
Yeah, please.
Okay.
Because we have
Fine.
last 5 minutes.
Yeah, fine. So by error, 18 months infant has administered Tdap instead of DTAP. Is it a valid dose and revaccination is required?
Theoretically, it's a valid dose. Theoretically, any Tdap, if it is not part of the primary first 3 series, 4th, 5th dose is considered as a valid dose. But here, what about the other antigens that you need at 18 months? So you have to repeat the dose.
Okay. Similarly, suppose 4.5 years, because like they gave, instead of DTAP, they give Tdap. What will you do?
Then you don't have to repeat the dose for that.
So you
There's
give
no
it at 9 to 10
recommendation.
years. 9 to 10
You
years.
give it 10 years, 9 to 10 years only.
Chetan, you understand what Dr. Kasi said. At 18 months, if you give only Tdap, you need to give the other antigen. Secondly, you ensure that though it is a valid dose, you ensure that the
antibody titers are
subsequent booster doses are given.
Right. Okay. So this is the last question, Bhajan sir, before we wind up our questions. A child came me at 6 months, the same, I think.
Yes.
6 years old and who has received Tdap instead of TTAP booster. What should we do?
Discussed, yeah.
Nothing.
I think, okay. And what is the latest recommendation regarding TT, TD and Tdap boosters? So I think we discussed that part also.
Yes.
So that's all from my side. Bhajan sir, you can.
Yeah. We'll take few questions from chat box. 8-year-old who misses his second DPT booster comes for vaccination. How to plan his Tdap schedule? Dr. Surojit Majumdar has asked.
And can you just repeat the question?
8-year-old who misses his second DPT booster comes for vaccination, and how to plan his Tdap schedule.
Okay, now this child is beyond 7 years, so you cannot use the full component, AP or WP. So you got to use only Tdap. The recommendation by the ACIP of USA is that if a delayed second booster is a Tdap, and if it is given before 9 years, you give it and then you repeat the adolescent booster at the usual age. But if the delayed booster is given after 9 completed years, then you can drop the adolescent booster dose.
Okay. Now, Dr. Ashwani Agarwal has asked that what are the effect of repeat TT in long run? Repeated, I mean, that even a few more are given. I mean, that is what I think he wanted to ask.
It leads to Arthur's phenomena, where your antibody complexes get deposited and can really have disastrous effect.
Oh, right. Yes, Chetan.
Yeah, so actually in this particular multiple doses, what happens is when you're giving frequent TT doses, you have very high antibody titers. Now in this high antibody titer, if you add more antigen, the antigen antibody complexes are formed, which get deposited in the skin, kidneys, and you can get an immune complex mediated disease. Classically, you get that swelling at the site with the orange peel appearance. You know, that a classical Arthur's reaction. It also reduces the immunogenicity because much of the antibodies get bound by the antigen. So even the antibody titers can drop and the effectiveness can become less. So not only is it from the adverse effect, but even from the efficacy point of view, repeated doses may blunt the immune response. Efficacy.
And deposits in the kidney, in the global.
Yes.
Yes.
Sir, there is a question that hepatitis B, we have a dose that is 0.5 ml what we are giving, right?
Hmm.
So after what age should I give the adult dose? That is
18 years. 18 years.
18 years. Now
Chicken pox
suppose,
12 years. Hepatitis B 18 years.
right. And
Hepatitis A 18 years.
that three things. Now suppose the child is 16 years and by chance he has given the adult dose, double the dose.
No problem.
No problem.
No
Dr.
problem.
Kasi, chicken box 12 years in mean to say the cutoff for interval
Yes.
between two doses, right?
Yeah.
Yeah,
Both
Dose
require
will
2
remain-
doses.
Yeah, the dose will remain same, no?
Those will remain the same.
Or
The
varicella.
interval. The interval.
Yeah,
Interval 1 month and 3 months.
Yes.
Okay. And for hepatitis A, it is inactivated. You have to change the dose, right?
Yep.
Adult, 720 and 1440.
I mean, if an adult you give the pediatric dose, you got to repeat the dose.
Right.
But if a child receives the adult dose, there's no harm.
Suppose the child has received the hepatitis B on the buttocks. What will you do?
It's an invalid dose. You got to repeat it. You discount the dose and give a repeat dose.
two vaccines, anti-rabies and hepatitis B.
Yes.
Yes.
Very even
that is
hepatitis, even HPV also.
HPV also, yeah.
right. So, sir, accelerator schedule and rapid schedule is same?
Yeah.
Same.
Same.
Okay. So, then I think I don't have much. This is interesting. Somebody asked me from my friend from Pakistan is a pediatrician. He said that someone is traveling from Karachi to India, right? So what is the recommendation for OPV for them to come here?
They should have received 1 dose of OPV or IPV less than 12 months before their entry into India. That is a new recommendation by the government of India. All polio endemic countries. They have
So
enlisted about 8 countries, I think, in this thing.
So minimum 1 month before it has to be taken?
And not more than 12 months.
Okay. So
2 weeks and 12 months.
So OPV or IPV?
OPV or IPV.
OPV or IPV, right?
IPV, yes.
There is a change in this. In the past, it was only OPV, I guess.
And
yes, now it is OPV or IPV.
Or IPV.
Okay. And suppose this is theoretical. Refugees, they come in India from Pakistan. What the government will do? Will they check for the titers or they will give the IPV immediately?
Just give 1 OPV dose to everyone.
OPV.
OPV, because see, OPV is more feasible. Now for mass immunization, it is still OPV. If you have CDVPV outbreaks, it is still MOPV2, not IM. If you remember, the first CDVP outbreak that took place after the switchover was in Telangana.
Hyderabad,
And at that time, they gave intramuscular full dose IM IPV, 2 doses to about 30,000 population. After that, the WHO recommendation came that you should not use IPV for outbreak response. It has to be only OPV. So MOPV2, now it is the NOPV2 that is being used. NOPV2 has now received licensure. So it is being used all over the world now.
Dr. Kasi, why did WHO go against intramuscular IPV? Stocks?
Shortage.
Yeah.
Shortage, that's all.
Scientific
No,
reason.
not because it's not good, it's the shortage. And see, basically, we have to accept that OPV gives better mucosal immunity compared to IPV. There's no doubt. And in an outbreak, what you require is good mucosal immunity. So as long as you get an IPV with good mucosal immunity, it won't be the vaccine of choice for outbreak. A lot of studies are now being done for producing IPVs with mucosal immunity. And there was one trial done with this DMLT, the double mutant lethal toxin of cholera. They added that and saw the response. Somehow it has been very disappointing. So far, no headway has been made in this.
There is a big controversy over this.
Yeah, Bhavajana sir, anything else?
Let's not get into that.
I think we have come to an end of this session.
So before you wind up, Bhavajana sir, I must say it was really a treat to listen to both of these maestros.
As always.
For me to listen to Dr. Kasi, as usual.
And Kashi sir is giving the explanation like amazing.
As always, we are blessed and privileged to have such an elite faculty with us at Gujarat Pediatrician WhatsApp group. And my profuse gratitude for both Kasi sir and Vijay sir for the time and consideration.
I must admit on this platform that I keep reading a lot. I'm into vaccinology for the last several years. But the way Dr. Kasi precisely puts it
Yes,
up.
yes, yes. It's a
Excellent.
treat to hear. I mean, use the
It's some
simply,
music to the
yeah, yeah. And last but not but least, since the beginning of our group, Dr. Nitin Shah sir has been a
Yes.
pillar.
We have missed him today.
And sir, you will be amused to know that he is so much I mean, ready to help, that anyone who asks any question within 5 minutes he reverts. And if that answer is long, then he will send him audio message. I mean,
Yes.
after even 20 years of his being president, he is such a popular person with the common pediatrician due to this his traits. So once again, I am grateful to Dr. Nitin Bhai because he is there since the beginning. And all Gujarat Pediatrician members who have been very self-disciplined to make it one of the most vibrant group. And thank you so much, all those who attended today's program. And those who couldn't due to clash of the program, we have got our Gujarat Pediatrician YouTube channel. They can subscribe to it. And once the recording is available, then we'll share this recording also of part 2. And please be there next month. As Nitin Bhai say, that next month we are coming with pediatric endocrinology. And because we won't clash now as on Thursday, so he has kept it on Friday, I think. Yeah. So,
Ramesh,
Vijay Bhai, please.
See, there was a webinar under the IPA banner, IPA,
Yes.
where today Dr. Tanu Singhal discussed torch infections. That
Yes.
was one of the best webinars I have heard on torch. This is something which is not discussed very often, and I'm sure recording would be available.
Yeah, we would like to
You
share.
have a huge followers in your group.
Yes,
So
sir. No,
just
sir.
a message that it is
Please
worth.
share it if you get it, and we
Yeah,
will
I'll
be
share.
very happy. Yeah. Thank you so much, sir. And thank you and good night to everyone. Thank you so much once again.
Thank you, Vijay.
Thank you.
Ramesh.
Thank you, sir. Thank you, Kasi sir. Thank you,
Thank you.
Chetan. Yeah.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye, sir. Bye.